Hello everyone. This is G. Tirlogachandar, MPT in Sports, Lecturer, Faculty of Physiotherapy, Dr.M.G.R.Physio Educational Research Institute. Today we are discussing about the joint mobilization technique. So joint mobilization. So mobilization means by using the passive mobilization to the joint, applying the forces, external forces to reduce the pain and increase the range of motions. So manipulation means it's a high velocity thrust. It is involving for improve the range of motion. These are the two techniques today we have discussed about that. Then initially we go for shoulder joint. This one. Supine. So today we have discussed about the shoulder joint mobilization. So indication for shoulder joint mobilization is a primary for we use it for pain and also joint stiffness, like periarthritis shoulder, other kind of joint shoulder arthritis, sternoclavicular immobilization, and post-operative stiffness, like that. So many conditions we use it for shoulder joint mobilization. So during shoulder mobilization, we have to know about the concave surface and convex surface. So concave surface of the shoulder is in the glenoid fossa of the scapula. Convex surface is head of the humerus. So during the stiffness, shoulder joint stiffness, like a PA shoulder, other tendinitis conditions, bicipital groove impingement, other kind of impingement, and capsular tightness pattern. So these all are the conditions involved for shoulder range of motion restrictions and also pain. So both conditions, both the restrictions and pain, both the condition we use it for joint mobilization. During mobilization, we have to apply for 5 grades. Grade 1 is at the initial stage. It for reduce the pain and improve the relaxation of the muscles. Then grade 2 for we have to apply in the mid range. Grade 3 for mid range 2 at the restriction level. Grade 4 at the restriction level. Grade 5 for beyond the restrictions level. These are the grades of manipulations and mobilizations. We have to apply for shoulder now. So first one, have to promote the flexion and internal rotations. So many conditions like pec minor tightness. Pec minor tightness involved for medial rotation of the shoulder and adductions. So these conditions will be restricted in external rotation and extension. So we have to promote that. So during that time, before the manipulation, I have to release my pec minor. Then I have applied the manipulation in downward position, like posterior gliding. So position of the patient in supine position. So now in AP glide, anterior posterior glide, in our posterior glide. So during this glide will improve the flexion of the shoulder and medial rotation of the shoulder. So few conditions will be restrict the flexion and medial rotation. Okay. So during this glide, I have to fix the scapula. By using the own body weight. I mean person's body weight. Then I have to give for holding my hair. This is called as gun hold position. So holding like this, gun hold position. Then I have to fix the scapula. Then give the downward pressure. During AP glide, anterior posterior glide, fix the scapula. Then I holding the margin of the head of the humerus like this. I give the downward pressure. In this glide, I have to apply for 1 or 2 glides per second up to 2 minutes. Now only it will be effective. Okay. Grade 1, I have to give for like vibrations like this one. Grade 2 and 3 and 4 for I have to apply for 1 or 2 counts per second. 1 or 2 for 2 per second. Then up to for 1 minute like this. So this one for grade 1, I am applying for downward pressure. 1. Like a Y position at the beginning range. It helps for reduce the stiffness and muscle spasm, leads to pain also reduced. Now I applied for grade 2. Grade 2 for at the level of restriction. So when the condition extension and lateral rotation will be restricted. So extension, lateral rotation will be restricted mean you have to apply for a concave convex rule. So during in that rule, according to concave convex rule, once concave surface fixed mean convex surface of the surface move for opposite direction. Concave surface fixed mean convex surface of the joint will be moved for opposite direction. That means during extension, the head of the humerus will move for downward. During extension, will move for downward sideline. Now patient complained with restrictions like these movements. Okay, may chance for supraspinatus tendinitis and anterior capsule tightness and also inferior fiber tightness. Extension restrictions and also external rotation restrictions. That means, so concave surface of the scapula will be fixed, head of the humerus will be moved for like this, anterior gliding and inferior spinning, anterior gliding and inferior spinning. So according to that law, during the mobilization, I have to apply in same way, okay, like this. So initially fix the scapula, like this, then I give the mobilization. At the pain-free range for grade 1, the mid-level is grade 2, then mid to beyond the restriction level is a grade 4, mid range to beyond the restriction level grade 4. Then once I reach the grade 4, I will apply for small high velocity thrust like this. It's called as grade 5. Grade 5 will help for increase the range of motion. Grade 5 help for increase the range of motion. Grade 1 and grade 3 for reduce this pain by using the mechanoreceptor relaxation, then stretch reflex relaxations and also muscle spasm reductions. Grade 2 and grade 4 for increasing the range by using applying the large amplitude. Grade 3 and grade 2 for large amplitude. So during mobilization, we have to use it for 5 graded. Grade 1 is small amplitude. Grade 2 and grade 3 is large amplitude. Grade 4 is small amplitude. So grade 1 is we use it for at the start of the range. Grade 2 large amplitude for at the starting range to mid range of the motions. Grade 3 is mid to beyond the mid level. Grade 4 is at the end of the restrictions level. Grade 5 is high velocity thrust. We use it for only in spinal and some excessive restrictions considered capsular tightness patterns only we are used for that grade 5. So first one, grade 1, my scapula, concave surface of the scapula will be fixed. So my head of the humerus will be moved. Okay, during extension the movement will happen in anterior direction. Okay, then during internal rotation it will happen in medial, anterior medially, like spinning will happen. Okay, so restrictions mean, during extensive restrictions means my anterior capsules or posterior capsules will be tight. Posterior capsules will be tight means it will be restrict the anterior gliding. So that time I use it for fixing the scapula in same direction. So this for grade 1. Grade 2 for up to mid range. I have to give 2 to 3 oscillations per second up to 2 minutes. Grade 3 for from the mid range to restriction level. Mid-range to restriction level. These also I give small amplitude. Two or three counts per second up to 2 minutes. Grade 4 for at the end of the restrictions level, small amplitude. Grade 5 for I start from the grade 4, then I give high velocity thrust like this. This is anterior gliding, shoulder. Okay, so this is the shoulder mobilization. This is the anterior gliding. Then we go for inferior gliding. So inferior gliding. So during shoulder inferior gliding, we have to position the patient is side lying, and also supine also we can use. So during side lying, I fix the scapula here like this. Then I hold the humerus, shaft of the humerus. I give some distraction force, pulling force. Then downward. This is the inferior gliding. It helps for improve the abduction and external rotation. Or I can use the Mulligan belt, or I can use the, some assistant support. So I use my both hand also. So inferior gliding, right? So now posterior gliding. So during posterior gliding, patient will be supine position. Shoulder will be maintained at the 45 degree of angle. Now scapula will be fixed by couch. Then holding the head of the humerus or shaft of the humerus like this. Then I apply downward pressure. I can apply up to 90 degree of the shoulder flexion. This is the posterior gliding. So during posterior gliding, we will improve the flexion and the medial rotation. Now we go for anterior gliding. So during anterior gliding, I fix the acromion process of the scapula. Then shoulder will be 35 degree of flexion. I give some downward pressure to here. Grade 1 is like a vibration technique. Grade 2 I will give for 2 to 3 oscillations per second. Grade 5, at the end of the restriction level, I give high velocity thrust. It will be helpful for improve the range of motion, right? I can use for same gliding at 90 degree of shoulder abduction. Now elbow mobilization. So during this mobilization, you have to apply for radio-humeral mobilization and ulno-humeral mobilization. Radio-humeral mobilization and ulno-humeral mobilization. So during ulno-humeral mobilization, I place my hand over the ulna like this. Then another hand will fix the lower end of the humerus. Then I will apply for distraction force like this. Then I will apply for downward force. This is for ulno-humeral mobilization. Then we go for radio-ulnar mobilization. Patients in same supine position. I am applying for, I am holding the head of the radius like this. Another hand will support the lower end of the humerus. Then I will apply for downward pressure. This is the radio-humeral mobilization. We go for radio-ulnar mobilization. So radio-ulnar joint has two joints, superior radio-ulnar joint and inferior radio-ulnar joint. So during these both joints will be restricted most commonly, post-traumatic stiffness and also tennis elbow and also golfer's elbow. These are major conditions and involve for restrictions happening in these two joints. So during the superior radio-ulnar joint mobilization, I have to fix the lower end of the humerus like this. Then I hold the shaft of the hand. I hold the one hand to lower end of the humerus. Another hand will place the forearm. I will give like distraction force. Then I will assist the supination and pronation. This is the superior radial ulnar joint mobilization. Okay. Now we go for inferior radial ulnar joint mobilization. So during this joint mobilization, I can use my thumb. So one thumb will place the ulnar, head of the ulnar, another hand will place the radial lower end of the radius. Then I give the downward pressure like this, alternatively. These will help reduce the joint stiffness and also improve the supination and pronations. So during wrist mobilization, patients will be supine position, then a hand will be rest, forearm muscles will be relaxed, then holding the like this. Distal end of the radius and ulna will be fixed by padding, then I applying the downward force like this. Then these movements during downward mobilizations will support increase in flexion. Comfortable here? Okay. Now these will be improve the extension of the wrist. Then during a mid prone position, by applying pressure over here, like downward pressure, this will be increasing the radial deviations and ulnar deviation. Next, so we come at the end of this session. So today we are discussing about the shoulder mobilization, elbow mobilization and wrist mobilization. Thank you.